A very warm good evening, namaskar, pranams to everyone who's logged in today. I'm so happy. It is such a privilege and pleasure to kickstart the 12th annual CMRE International Symposium in Diabetes, jointly organized by Dr. Rajiv Chawla and me as directors of CMRE, along with the first and most important DIPSI symposium, because pregnancy is something which is very, very close to all our hearts. And we thought, why not start with an in-family symposium first? A very close-knit DIPSI family, people who are really focused on providing best care not only during pregnancy but before pregnancy and after pregnancy to all the women in our country as well as globally, and also their offsprings. So today we will have a lot of scientific discussion, and all the stalwarts in the field of pregnancy and diabetes are here. So I'm sure our delegates are going to be very, very rich with the discussions that we have today. To give a context of CMRE and the DIPSI symposium, I now invite Dr. Rajiv Chawla, my co-director, who will welcome all the faculties once again. And after that, I will also request Dr. Seshia sir, our founder, our mentor, our guide, very, very respectable, a fatherly figure to all of us, to say a few words. Dr. Chawla, please.
Good afternoon, everyone. Charan Vandana, sir, and my namaskar to all DIPSI members. It is always a pleasure to be part of this CME or webinar year after year. So it is my proud privilege today to welcome you all to the 12th International Symposium being hosted by CMRE, ASD, and DIPSI across the globe. We are now streaming live. Not only it is being telecasted across the country, all those delegates, those who have logged in, so we welcome them. It is also being streamed live to Middle East, Egypt, and part of Europe. So it is always a pleasure to be starting our day with the DIPSI Symposium. As Dr. Shalini very rightly said, we are all part of the same family, and we are fortunate enough to have our godfather, is Professor V. Sheshai,
Yes,
who
sir.
is a fatherly figure to all of us, not only mentor, he has been a guide and teacher to all of us. So once again, we open this international symposium today with the DIPSI Symposium. And it is a real pleasure to have you all amongst us, Professor Hema, Professor Sujata Mishra, Professor Samar Banerjee, my elder brother, I always call him Dada, and my sister, Dr. Bhavdharni. So it is with great pleasure we open this symposium today. And before we go for Saraswati Vandana, we will like to have blessings from our Professor V. Sheshai, who is a father to all of us. Sir, for 2 minutes, we need your blessings, sir. To start this session, to start this international symposium, we need your blessings, sir.
So just introduction.
No, I think it is blocked mine. That was gone.
We can hear you, sir.
No,
We can
sir,
hear
you
you,
can
sir.
just give your words.
No, can you hear me?
Yes,
Yes,
sir, we can
yes,
hear
sir.
you.
We can hear you, sir.
It's a great, great God's wish that I should be able to participate today. Anyway, some problem I face. Because you have called me, that I said I'll definitely come and sit and talk to you people. And I see this great people going to speak today. My Sama, my Hema, and this Mishra, Sata Mishra, Bhavdharani. I'm very happy to see all of you. In spite of it, today's problem, I'm sitting over here to listen to you. For 2 hours, I'm sitting here. I wish you all the best. Hope everything goes on very well. Rajiv and Shalini, thank you very much for inviting you for this symposium on DIPSI and CMRE. I wish you all the best. Thank you very much.
Thank you, sir. That's a
Thank you,
God
sir.
grace, and it is so inspiring that in spite of the fact that you may not be well, still you are there, part of this DIPSI Symposium, which is our family, and you know that without your blessing, we never start a session. So over to RX team for Saraswati
Saraswati
Vandana
Vandana.
and then Dr. Shalini to start the sessions.
Sound?
RX sound is not there.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Thank you so much. I think especially in these auspicious days of Navratri, invoking the goddess's blessings for a very successful academic feast that we've laid out for the next 3 days. I'm sure we starting with the grand DIPSI CMRE symposium to kickstart. We have some stalwarts from this field who are going to share their knowledge today with all the delegates. So to kickstart, let me invite our very, very respected Samarda, Dr. Samar Banerjee, a renowned figure in the field of diabetes as well as pregnancy. Sir is Professor, Department of Medicine, Specialist Diabetes Clinic at Vivekanand Institute of Medical Sciences, Kolkata. He's been there and done all. Past President, RSSDI, DIPSI, Indian Society of Hypertension, President, Association of Clinical Diabetology, has been Editor-in-Chief, Journal of Clinical Diabetology, and he's authored 12 books on diabetes. Extremely academic, the go-to person if you want, if you have any doubts on diabetes or diabetes in pregnancy. One of the founder members of DIPSI. He's held a number of prestigious positions, chairman of API, most recently president of RSSDI. So over to sir, and he is going to enlighten us on a very hot topic today. GDM, we all thought conventionally is second trimester or third trimester diagnosis of dysglycemia in pregnancy. But now, with such a huge load of diversity in our country as well as globally, we are seeing GDM being diagnosed much earlier in pregnancy, right in the very early pregnancy, the term that has been coined as early GDM. So Dr. Samar Banerjee, sir, the stage is all yours. Early GDM, what is new?
And just to share with you, Dr. Shalini forgot that we are publishing this quarter only our study from
our
both
very own data on EGDM.
EGDM.
It just got accepted. And that is our, I think, one of the initial datas on EGDM where we've actually diagnosed GDM at less than 12 weeks, average about 8 weeks. So that is just accepted for publication. That's the first twin center data from North India, Dr. Chawla and my data.
Over to you, sir.
Over to you, sir.
Is my slides visible?
Yes, sir.
So your audible slide is very well visible.
Thank you. I am going to discuss today a few points of early GDM, which is very close to my heart. I am going to discuss what is new. You are hearing it for so many years, but what new I just discussed. Why pregnancy diabetes problem is occurred, there is diminished increased insulin sensitivity diminished glucose upset, then insulin resistant substrate 1 expresses in minimized, inflammatory response are aggravated, and reactive oxidative stress are all increased. These all occur in the muscle. In the liver, there is diminished insulin sensitivity, increased gluconeogenesis, diminished sex hormone binding globulin, increased inflammatory response. Similar changes are also occurring in the fat, body fat, and placenta. And final result is neurohormonal dysfunction, inflammatory response, oxidative stress, imbalance of gut microbiota, finally leading to insulin resistance, hyperglycemia, and gestational diabetes. Early detection and initiation of treatment in GDM is important because unrecognized and untreated GDM is responsible for an important proportion of maternal and fetal adverse outcomes like pregnancy-induced hypertension, preeclampsia, UTIs, more cesarean delivery, fetal macrosomia, birth trauma, neonatal hypo, and future diabetes. This is a paper by Bengali person Saptasi Bhattacharya, Early Gestational Diabetes Diagnostic Strategies and Clinical Importance. During screening in pregnancy, significant proportion of women do not reach the threshold for overt diabetes. That means postprandial 2 are above 139, but fulfill the criteria used for diagnosing conventional gestational diabetes. Early GDM refers to intermediate degree of hyperglycemia detected before 24 weeks of pregnancy that fulfill the criteria for conventional GDM but fall short of the threshold for overt diabetes. And here we lead that any fasting sugar, we are giving more importance to fasting also, more than 92 should be considered as eGDM in the first, second, or any trimester. This was the ADA recommendation published 23, which they are still maintaining that before 15 weeks of gestation, they allow only test for high risk factors. And they claim there is no benefit if you screen earlier. And for all average, routinely 24 to 28. But India is a predominant country for insulin resistance, higher incidence of GDM, so don't obey this. Insulin is detectable in the fetal pancreas. When to do screening? I'm giving you the logics. As early as 9 to 11 weeks, increase in pancreatic beta cell mass, insulin secretion in the fetus occurs by the 11th week of gestation response to maternal hyperglycemia. If the fetal beta cell cannot cope up with the maternal hyperglycemia, fetal beta cell fails, there is fetal hyperglycemia, and there is damage to the fetus. So we believe it should start, if not before 9 to 11 weeks. This is a paper published by my professor, my teacher, my mentor, my guide, everything, Professor Sesaya, who published in 2008 that out of 87 cases of GDM diagnosed, 41.4% were diagnosed before 12 weeks. So if you go to the guideline by the ADA to do at 24 weeks, the cases will be much aggravated. And 20.7% by 13 to 23, and 17.2 by 30 in 24 to 30 weeks, and beyond 30, 20.7. So altogether, if we go for diagnosis in the first trimester, we can detect 62.1%. So DIPSI recommends screening at the first visit, even if possible, before pregnancy. This is a study which shows that what is the normal blood sugar? Fasting blood sugar in pregnancy is 71 plus minus 8. 1 or 109 plus minus 13, and 2 are 99 plus minus 10. So the values are coming as fasting less than 90 and postprandial 2 are below 110. So if this is normal, why will wait up to 139 or fasting up to 95 to declare the patient is diabetic? And these intermediate values, postprandial between 110 to 119 and fasting between say 80 to 95 are already damaging the fetus. What are the result of this damage? Normalization of fetal hyperinsulinemia, which is related with maternal hyperglycemia, is related to fetal abdominal overgrowth. So if there is fetal hyperinsulinemia, there will be more and more fetal abdominal overgrowth, large for gestational age, baby, metabolic abnormality, and this will occur especially in the high-risk older and obese GDM women. Australian Diabetes in Pregnancy Society recommends screening high-risk women for GDM before 20 weeks of pregnancy. Early GDM detected had a significantly lower newborn composite outcome frequency. There is the complications of hypo, birth trauma, NICU admission, stillbirth, neonatal death, respiratory distress, and phototherapy compared to diagnosed late. Primary cesarean, hypertensive disorder, postpartum hemorrhage, birth weight more than 90 percentile, macrosomia, and preterm birth frequencies were not significantly different between the groups. But these problems which I just mentioned earlier is not negligible. Therefore, high-risk women diagnosed with GDM in early pregnancy were not more likely to have an adverse outcome compared to routinely diagnosed people. This is a study by Akineni et al. 28.6% were diagnosed before 24 weeks. GDM before 24 weeks were older and more likely to be obese. A significant number of these women also had identifiable risk factors for GDM like hypertension, dyslipidemia, family history, previous history of gestational diabetes, diabetes in the first degree of relative, prior delivery of fetal macrosomia, and previous history of congenital fetal anomalies. So I tell that these points which I just mentioned, if these be present, the test should be definitely in the early stage. This is another paper. This is a paper with them. Same paper, 7.8% were diagnosed with GDM and 28.6% were diagnosed before 24 weeks. Women diagnosed with GDM before 24 weeks were older and more likely to be obese. This is a paper which shows that GDM recurrence and distribution of early rate and really late diagnosis of recurrent GDM. Early GDM minimum prevalence 43% in this paper. Women with early recurrent GDM showed early dysglycemia in the second pregnancy. So, history of early GDM in the first pregnancy means also early dysglycemia in future. This, however, in this study, early GDM was not associated with pregnancy outcome. Why? Why early GDM did not lead to problem? The question is, the patients having past history of GDM or early GDM were properly counseled regarding lifestyle and other figures. For that reason, the problem did not come. What are the advantages of early screening? Partha et al. Showed that it can avoid diabetes-related complications such as polyhydramnias, fetal anomalies, and preterm BD. Ryan showed that there is improvement in the outcome of emergency cesarean section, neonatal hypo, and macrosomia. A large French study found that early screening were more likely to be insulin treated during pregnancy, gained less gestational weight, had a lower rate of preeclampsia and similar rate of large for gestational age infants and shoulder dystocia. This study also shows that accounted for 65.9% of all GDM, and this is from Thailand. It is showing the highest incidence of early GDM, 65.9, and they claim despite treatment, there was increased risk of preeclampsia, LGA infants, and NICU admission. Independent associated factors were age, above 30, previous gestational diabetes, while DM in family was the only independent factor of late onset diabetes. Basir et al. From the Middle East, at conception, EGDM women who were older had higher body mass index compared to usual GDM. The mean fasting and 1 hour blood glucose levels were significantly higher in early GDM. More patients in the universal GDM or conventional GDM were managed on diet alone compared with EGDM. EGDM subjects gained less weight per week and they required insulin much earlier. Another study by Sweeting and all, hypertensive disorder in pregnancy including preeclampsia, preterm delivery, cesarean section, and neonatal jaundice more prevalent with pre-existing diabetes and early GDM. Macrosomia neonatal intensive care admission in women in whom GDM was diagnosed before 12 weeks of gestation were comparable to rates seen in women with pre-existing. So, diabetes developing before 12 weeks they behaving as pre-gestational diabetes in terms of some complications. Nusrat Parveen et al. From Iran, they showed that past history of GDM, macrosomia, and stillbirth were significant predictors for early GDM. I am not going to the details of the risk which I have discussed in earlier studies. Most of this adverse pregnancy outcome can be prevented through early registration and screening, close follow-up, growth ultrasound, and provision of efficient emergency and neonatal care. This is a study by Hillier et al. Women without risk factors are universally screened at 24 to 26 weeks. Early screenings, mean average 10 weeks, were recommended in obese and other high-risk women. Average gestational weight gain for all women was 12.8 kg. 10.7% women were diagnosed GDM. Average gestational weight gain for all women diagnosed with GDM were 10.7 kg. Women with e-gestational diabetes, 2.4 kg less gestational weight gain. So compared between all the cases of GDM, e-GDM are having less gestational weight gain. Among obese women, only women diagnosed with e-GDM averaged overall gestational weight gain. Results suggest that e-GDM diagnosis in high-risk women is beneficial for optimizing gestational weight gain. This is another study by Riskin. A total of 6,129 women had a fasting glucose test at median of 9.5 weeks. There is strong graded association between fasting glucose and primary outcome. The frequency of GDM development increased from 1% in the lowest glucose category to 11.7% in the highest category of glucose level. Frequency of LG neonates and macrosomia increased from 7.9 to 19.4. Primary cesarean section also increased. The conclusion of the study is higher first trimester fasting glucose within what is currently considered a non-diabetic range increase the risk of adverse pregnancy outcome, and early detection can even prevent this one. It is a study that with the screening for gestational diabetes in early pregnancy, what is the evidence? What are the documents? Observational studies show conflicting results as to whether screening and treatment of GDM in early pregnancy is beneficial. I have some different studies. Some are claiming benefits in some points, some are in other points, and some in whole point. Evidence from large, we require large random compromised trial, also educating lower risk involving the lower risk population to determine whether this early GDM diagnosis is really useful or not. In this study, GDM was diagnosed either at the first antenatal visit when fasting plasma glucose was 5.1 ml, that is around about 92, and the early diagnostic group at 65.7% women, the late diagnostic group at 34.3%. The early diagnosis group had more obese women. In the early diagnosis group, GDM was more frequently diagnosed in women who gained less than 11 kg. Fasting plasma glucose higher in the e-GDM group. Polyhydramnios and preeclampsia are more common in the late diagnosis group, and there are more large for gestational baby. This study shows that GDM in the first trimester was up to 51%. Out of 2,285 live births with a median delivery of gestational age of 38, 7% were large for gestational age neonates. And the relative risk of having LGA neonates among women in DM and GDM was 2.3% and 0.8%. They also claim that early detection may prevent this. Of 58 studies, analysis, 41 reported a prevalence of e-GDM, BMI, previous history of GDM, family history of diabetes, and multiparity were reported as e-GDM risk factors. Adverse pregnancy outcome were associated with e-GDM, and they are macrosomia, cesarean delivery, induction of labor, hypertension, preterm delivery, shoulder dystocia. This is a study by David Simmons et al. Multi-center large study. These are labeled as topogome study, and these has cleared all our conclusion. Testing early in pregnancy to exclude undiagnosed diabetes is recommended by ADA for women who are at high risk. If glucose levels are increased but below values that are diagnostic of diabetes in non-pregnant adults, early gestational diabetes is diagnosed and treated. And they performed a randomized control trial to assess pregnancy outcome after treatment for GDM had been initiated before 20 weeks of pregnancy. The results support the observation that hyperglycemia often occurs before 24 to 28 weeks in women with risk factors for gestational diabetes. But we need further research in regard to the extent to which this observation reflects women with pre-existing mild hyperglycemia. In this trial involving pregnant women who had a risk factor for hyperglycemia, immediate treatment of diabetes before 28 weeks led to modestly lower incidence of a composite of severe adverse neonatal outcome than no immediate treatment. But between group difference with respect to pregnancy-related hypertension and neonatal lean body mass were not significant. So this topogam study has cleared there is definite advantage with majority of the factors of the neonate. Exploratory subgroup analysis suggested a possible benefit of early treatment with respect to the composite adverse neonatal outcome among women with OGTT before 14 weeks. These analyses also suggest that with early treatment, there is a possibility of an increased risk of small for gestational age infants among mothers who had OGTT results that were in the lower glycemic range. What is the need? Professor Seshaiya published a paper in 2016 to test it early. In a cohort of 11,780 papers, the pregnant women who underwent the test in first, second, and third trimester were 4,300, 4,632, 2,853. Among them, 31.5%, 43.2%, and 25.3% were in the first, second, and third. So 31.5% were in the first trimester. Positive family history of diabetes and history of fetal loss in previous pregnancy was more common in women diagnosed with GDM in the first trimester. Fasting plasma glucose 92 in early pregnancy is associated with worsened perinatal outcome. This is finding, including a high chance of large for gestational age, macrosomia, even in the absence of the later development of conventional GDM. Pre-pregnancy BMI in the overweight range or above, in conjunction with fasting plasma glucose 92 or above, may represent pregnancy at high risk and meeting close monitoring. This is a study which shows also that among women undergoing early pregnancy, the pre-pregnancy body mass, depending upon the pre-pregnancy body mass, there is the development of that gestational diabetes. So higher the body mass, class 3 obesity, there will be more chances of development of early pregnancy. What do the recent studies add? This is the latest paper, June 25. Rajiv gave me the task of what new. I could not find anything after June. Early onset gestational insulin resistance is a distinct pathophysiological people. About 30 to 50% of women with early GDM regress to normal when tested at 24 to 28 weeks of gestation. Immediate treatment compared to deferred or no treatment is associated with modest neonatal benefit, chiefly driven by the reduction in risk of neonatal distress as shown by the toboggan trial. Treatment benefits are more apparent among women with OGTT values in higher glycemic band. So, gestational diabetes, earlier onset, higher blood glucose, treatment response are better, complications are less. Continuous glucose monitoring study, CGMS, has been done in early GDM to assess the advantages. A prospective observational study by Darnwall et al. Recruited 768 women before 17 weeks. In the gestational period to OGTT, women with GDM diagnosis had a higher CGM mean glucose. So even if we miss in conventional blood sugar testing, Darnwall has shown that a good number of cases are showing abnormality in blood glucose in CGM cases. Kosan et al. Compared women with early GDM and GDM. They also detected complications. They are more or less with the earlier studies. I'm not going to detail. The importance of screening early to detect overt DM was strongly proposed by IADPC, who in 2013 and FIGO also endorsed the necessity for early screening. DIPSI in favor of always doing the early screening, and the large studies, toboggan study has established a need for early screening two studies. One is TESGO, another is PINTO. We'll have to wait for final answers. Final answer is that doing blood sugar so earlier is whether cost effective or not. This is an extension of the toboggan study, and they have shown that diagnosis and treatment of EGDM are more effective and tended to be less costly compared with usual care. Subgroup analysis demonstrated that diagnosis and treatment of EGDM among women in the higher glycemic range, that means fasting 95 to 109, 1 hour above 199, 2 hours between 160 to 199 was more effective and less costly. The intervention was more effective, tended to be less costly among women diagnosed before 14 weeks of gestation. So this has cleared all our criteria regarding the cost-benefit ratio. That screening as early JDM is definitely helpful. What are the future tasks? Who should be screened for EGDM? Everyone or obese or with bad family history? This is a question. Which test is most dependable? OGTT, single blood sugar, fasting, postprandial, A1C, or combination of these tests. When it should be done, at booking or before 10th week or later. How should EGDM be treated? If EGDM is ruled out in early pregnancy, should we still screen for conventional GDM? We need more random control, large trials to answer these questions. But according to Professor Sesaya, he is of the opinion that detection of GDM is possible, but he wants there should be prediction when the lady is normal blood sugar level in pregnant or non-pregnant, whether before developing we can say or predict that she will develop pregnancy. First time NIH study in 2018 suggested A1C of 51.3%, that means 2 hours above 110 at 10 weeks of pregnancy predicts GDM. And also, no explanation has been given for prediction as well as prevention of gestational diabetes. So Professor Sesaya is much ahead of us, regardless of his age and seniority. He is not now interested for diagnosing diabetes. He wants to predict who will develop diabetes. What is the scope? Hence, blood glucose has to be brought to below 110 as fetal beta cells start screening insulin around 10, 11 weeks. And PPBS at 10 weeks should be less than 110. As I have shown that normal blood sugar 2 hours is below 110 in pregnant phase. With fetal insulin secretion, changes in maternal metabolism occurs. So in conclusion, I like to mention a considerable number of women are diagnosed as having intermediate level of hyperglycemia in early pregnancy. There is no consensus on the optimal diagnostic and therapeutic approaches for this large group having EGDM. Fasting plasma glucose, OGTT, A1C are being tried. Diagnostic cut of these indices have not been finally settled. Association between early pregnancy fasting hyperglycemia and adverse perinatal endpoints wholly irrespective of the development of late pregnancy GDM. Higher pre-pregnancy BMI could be an additional determinant of unfavorable outcome. Treatment of EGDM demonstrates conflicting results partially attributable to heterogeneity in study design. Well-designed, multi-ethnic, multi-centric, large clinical trial we require to define the diagnostic and therapeutic strategies for EGDM, taking into consideration the clinical and economic implications are debated. But I have started screening as early as the patient is coming to us. Through 1915, when insulin was not available, ultrasound was not available, Jocelyn regretted the next few years may show that pregnancy can take place in diabetic patients more readily than has been supposed. It is certainly true that with the improvement in the treatment of diabetic patients, diabetic women will be less likely to abort pregnancy. And I am showing some GDM babies which has been treated by me. They are very happy with me, at least showing their gratitude that they have been born very safe. I believe each and every case of pregnancy diabetes can give birth to this jolly, well, laughing babies if it is properly treated. Thank you for your present hearing. And according to Walt Disney, all our dreams can come true if we have the courage to pursue them. Because ultimately, GDM-free world means diabetes-free world, because GDM determines the future explosion of diabetes and other vascular diseases like cardiovascular, hypertension, cerebrovascular accident, etc. Thank you for your present hearing. Thank you.
Thank you, Dr. Samar, for an excellent oration on early GDM, a new concept which has now, I think, over last few years, it has evolved and a lot of evidence has come that this entity also exists, especially in our ethnicity. Caucasians still may not agree that early GDM may come as early as less than 10 weeks or less than 12 weeks. But I think in Asians and in Indian ethnicity, a lot of data has come. Dr. Piki from Delhi and Sheshai sir team, Dr. Anjalakshi from Chennai, they have shown that early GDM, it exists in our ethnicity and it may be possible to prevent diabetes or development of GDM if you intervene. What sir has been talking about is real new novel concept of primordial prevention. So with this, I think I'll request you to stay back till the end so that we have some discussion toward the end. So we will request Professor Shishai to talk on primordial prevention and evolving concept on which now there is a lot of data which is already published in Curious Endocrinology Journal. And it is Sir's own, 5 years ago, we thought that it was a hypothesis, but it is getting proven now. So primordial prevention today is a reality. And we have already, from the DIPSI side, a document was released in Delhi DIPSI where we said that primordial prevention of GDM is possible, and that was a DIPSI declaration, Delhi, which was released by Professor Jitendra Singh. So over to you, Professor B. Shishai. Sir, you need no introduction in national or any international forum. You are like a godfather to all of us, a living legend. I always say that in your time you have generated almost 40 years or 50-year evidence on gestational diabetes, and you have seen concepts getting evolved and getting accepted. That is very, very important that in your lifetime you have seen that this concept is also getting accepted based on the evidence which you have produced. So over to you for primordial prevention of GD.
Dear Rajesh Chawla, dear Shalini Jaggi, I am very happy. Samar spoke so nicely. He's written another book now, or when I'm hearing to him. And subsequent speakers will be there. Hema, Sata Mishra, and I wish Udit Tanawal is there. I call them three, what do you call, three musketeers. When DIPSI meeting started second time, all these people came, young people, they're all scared of me with this and that. And see how Hema has gone up. She is very happy that she's come up very well in life. So Rajiv and then Shalini asked me to speak on this topic, primordial prevention of GDM, an evolving concept. Hope I should be able to convince you people on this aspect. So this just introduction, estimation and projections of the number of people 2079 years with diabetes in different editions, millions. 2019 will be, it was 2019, it was again by 2021, again the okay, sir. This only yeah. Pre-diabetes approximately 380 million, which is likely to increase to about 481 million by 2040. Then diabetes is an epidemic of unprecedented magnitude. All of us know that. Now the probably it is called pandemic. So this is introduction. What is going to happen for us to meet in the future? Now, Savla told me to speak on this primordial diabetes. What is meant by that? Detection of diabetes does not mean prevention of diabetes. What I'm talking here will be here. What we need is primordial prevention of diabetes, that is, disease should not develop. So with this, I will little more theory here. Is it possible to achieve diabetes-free generation? Whom to focus? That is the answer we are going to give it now. Female gender is key for diabetes prevention. That is where we have to work on them. How the body's susceptibility to lifestyle diseases was programmed intrauterine. That is what told David Barker, very popular physician in UK. Now, what happened here? Then started developmental origin of health and disease, phenotype, genes, and then intrauterine milieu here, intrauterine environment, and then here postnatal environment. All things will meet together to produce epigenetics, and the epigenetic is going to produce here genetic loads the gun, and then the environment takes off. So environment is important. Of all this, it is important. Why it is so important? Because in the environment, gestational programming is a process of the stimuli or stresses that occur at critical or sensitive period of fetal development permanently change. Once development occurs, change not occurs though physiology and metabolism predisposing individuals to disease in adult life. Fetal or adult disease, that is another concept. So fetal is very, very important. So this development origin, many of us know about this. The womb is well supplied with mitochondria, but the sperm contains a few, even those few do not possess the offspring. So what happened here is at fertilization, it is only the nucleus of the spermatozoa that enters the ovum. Thus all the cytoplasm, mitochondria, and maternal DNA are exclusively maternal inherited. So with this introduction, now maternal hyperglycemia and progeny here, the offsprings, this is very important. Offsprings who were in vitro, when the mother had gestational diabetes, GDM, have a greater risk of developing diabetes. So then earlier siblings born before the mother developing GDM. So that clearly shows this is what happened here. Intrauterine video is very important. That is more than that inherited destiny. So that is what happened here. It will be hyperglycemia and pregnancy. So far it's over the GDM. Now we'll see what happens here. The effect of hyperglycemia on the fetus. Gestational diabetes mother GDM, mother's hyperglycemia is there. A placenta will be there. Now you'll see here, mother's insulin is going back. It is going to come back to the fetus. Whereas the fetus, infant or GDM, mother's hyperglycemia goes into fetal hyperglycemia, thus gives rise to impaired glucose tolerance, hyperglycemia, and that is what a big circle of mother to fetus. Now, gestational diabetes mellitus, GDM plays a crucial role in increasing prevalence of diabetes and obesity. Insulin resistance, increased atherogenic hyperprevalent, inflammatory markers, hypertension, endothelial dysfunction lead to increased risk of CNM. If you look at the data somewhere, it's found 74% of the people go to the end of life because of the GDM happened. So GDM is the mother of non-communicable diseases. That is what my concept is there. Now I move on to another angle here. Evolution of the diagnosis of hyperglycemia in pregnancy. How it's going to go? This is what evolution here. Detection. I think Sama told about detection here. If you see in this world, GDM is possible in very diagnostic criteria. Number of problem diagnostic criteria will be there. So what we want to say is prediction is at which week and glycemic level development occurs. That is again very, very important. Detection is over, prediction is very important. And finally, you have to go to the prevention, where is a measure to avoid the development of GDM and its consequences. Three things are very important for us. So with this introduction, now I'm going to give an important point here. You'll see, look at this. Diagnostic history of studies used for estimating GDP. Number of the ADA in this left side, number of countries have a different diagnosis, including our deep sea, nice, everything will be there. Which one to follow now? Okay, very popular IDPG. I am also once vice president, and now Rajesh Chawla is the IDPG. Now, how to follow the IDPG? IDPG guidelines needs revision. I'm telling. As even at centers accepted its recommendation, the approach varies. Who by suggesting that means he feels that still is not appropriate for the country or the world to follow IDPs. Follow only people in Asian countries. It's very difficult to follow IIDPG. And then take about United States, ADA, one country, ACOG. So like that, most of the different countries have different guidelines for diagnosis of gestational diabetes, and even the same country has two guidelines which lead to confusion among healthcare professionals. You'll see here, American College of Obstetrics and Gynecology, different one. ADA different. So this is what happens most of the countries. So what we should do, we don't want to follow this. What should we follow? Therefore, the physiological glycemic level in normal pregnancy has to be recognized and implemented. That's simpler answer. Physiology. What physiology? It's a wonderful study here. Pattern of glycemia in normal pregnancy. Even last week appearance also, you'll see in this study, for almost 40 this was studied and came to the conclusion is 2-hour PPG will be less than 110 milligram. This is a wonderful data came. Any value above normal is abnormal. So that Hernandez said this should be this is work. One wonderful work he said 110, less than 110. I will say why it is so important in the pregnancy. This is it should not cross more than 110. That is normal value should be that level. Not that so many value are given that time. Now having this, now we'll go to embryology. The embryology of fetal blood cell. This is another important message. Each islet cell functions as an endocrine organ. In this, the human pancreas begins to develop 4 weeks after fertilization, and first insulin deposit can be found. But this is very important message. Between week 7 and 8, pancreatic islet cells differentiates 10th and 11th week of gestation. That this very message everyone to keep this mind. 10th and 11th week gestation. So recognizes and represents the maternal glycemia at 11th week of gestation. So 10th and 11th week is very important to pregnancy here. 10th, we will come back to that. Why 10th week is important and 11th week is important. And I'll tell you what is the reason here. Now this is now we'll come here. And again, Samar told about that glycemic level at which gestational weeks prediction of GDM occurs, which week. Now, this is what he told in this study. Long time ago, first time, National Institute of Health Innate study in 2018 says A1C of 5.3. Otherwise, which is very difficult to follow all over the world, and particularly countries which are not very able to do the A1C everywhere. So 2-hour PPBS more than 10 milligram as a 10th week predict GDP. This is the message I must carry on. 2-hour PPG more than 10 milligram as a 10th week predict GDM, and because of that, what will happen? Yes, for prevention, I told you detection, no prevention. Hence, for prevention, blood glucose has to be brought to less than 110 milligram everywhere, anywhere. So that is what the first NIH study. Else, for prevention, blood sugar has to be 110 milligrams. Now, what will happen here? If in case if PPBS is more than 10 milligrams, fetal beta cells start secreting more insulin around 11th week. This is dangerous. As I told you previously itself, 10th week and 11th week. In case if more than 10 milligram fetal will start secreting more insulin, and 11th week, after that you cannot do anything is possible. Fetal hyperglycemia started, this maternal hyperglycemia. is fetal hyperinsulinemia. So, but so far, no further work has been done for prediction as well as for the prevention of JDM. This is an old story. Now, most of us, most of you speakers would have done this work here. So, no further work has been done for the prediction at that time. Now, we are coming to conclusion here, conceptualization, both endocrinology and embryology here. Maternal, very important, maternal true or postprandial blood sugar should not cross 110 milligram per deciliter at 10th week. That is very important we get told to mention. As fetal beta cells start secreting insulin around the 11th week of pregnancy. So 10th and 11th week always must remember, three things must be weeks, 10th and 11th week, and glucose 110 milligram. This is enough for us to remember. Now, which gestational week glucose tolerance to be screened. When to screen is very important. What we are thinking about here will be the early gestational glucose intolerance, EGI. I tell you why this. It's interesting on that. Early gestational glucose intolerance. I never used diabetes. Early gestational glucose, that's what it's called, EGI. Now you'll see here, ideal is to test for glucose tolerance at 8th week, that is 2 months. And then prediction of GDM is stored PPG more than 110 milligram, between 110 maximum up to 119 at 10th week. Prediction GDM is more than 110 milligrams. Then what could happen here? Hence, at the 8th week itself, because that's why I told the first slide itself, ideal is test for the glucose tolerance at the 8th week at 2 months. Hence, at the 8th week itself, 2 people has to be estimated if less than 100 milligram, followed up by monitoring CBG. The most dangerous here only here, in case 2 ppg is more than 10 milligrams, at the 8th week, a grace period 2 weeks available to attain 2 ppg less than 10 milligram at 10th week with MNT and metformin. So now we are getting a message here, 10th week, the 8th week is we have to screen 8th week itself, and by 10th week, blood sugar should not cross 110 milligrams. So this again published data here. Now what happened here? Once we establish that blood sugar level, now we go to embryonic stage. What treatment can be given here? This is very important message here. You will see here embryonic stage and then fetal stage. Now very important, because any drug can be given. Embryonic stage is over. 9th, 8th week is over, the yellow line. So by giving medicines or drug which is not going to be harmful to the fetus, because embryonic stage is over, fetal stage growth has occurred, there's no problem at all. So in that case, what happened? If a pregnant woman blood sugar more than 110 to 119, MNT and metformin 250 milligram BD has to be started and continued. Target glycemia to obtain ES2 or PPBS will be 99 plus or minus 10. That is the value. Nothing was given. That's why I put a red line there. Metformin is safe as embryonic stage in over by 8th week. Metformin is safe for use throughout pregnancy. It's from conception to birth. And again, lately, this is done in India, Delhi Apollo Hospital. Metformin use pregnancy did not show any adverse effects compared to with insulin long-term outcome in children. So now this is what happened here, an evidence-based here, subject expert committee. India said, following the review, the SCC has recommended the consideration of metformin, SR or whatever is that 500 mg per day for use during pregnancy. The treating physician's discretion as an adjunct or alternative to insulin therapy, because this confusion is going on in our country also about this, to give metformin, not metformin. I have given evidence-based, and also government of India has given, as mentioned here, subject expert committee has approved metformin. So, and now this is an important message here. Initiation of metformin or 12th week will not be effective in preventing GDM. This shows, again, as Samar told, no point in working out a 12th week. It's not possible. So it has to be done by 10th week and 11th week. Up till that time only. After that, in the treatment of metformin will not be useful. We don't know. You see, that child will become future will not be normal child, maybe problem will be there. So initiation of metformin should be done 10th week, early 8th week and 10th week, not 12th week. That is not the early screening problem. So 24th week, 16th week early screening is no point. So finally, coming here, the evidence, multi-centric study done here in the country, both from Delhi and as well as in Chennai, group A, that is normal fellows, 229 people, antenatal with 2 ppg, less than 110 milligram at 8th week. This is what I was told you earlier also. 2 or less than 110 milligram at 8th week, no intervention is possible. In case no intervention, 9 developed GDM, that is 3%, 96% did not develop GDM. So that is why less than 100 milligram, very safe blood sugar level. Next step will be here. In case GDM, group B, 250 antenatal women with postponed PPVS more than 110 milligrams. Suppose you don't interfere, you allow it to go without intervention, almost 90% develop GDM. So it shows treatment is very necessary in this 110 above. So finally here, group C, 189 with 2 ppbs, more than 110 milligram, and they were treated with MNT and metformin, 2 twice a day throughout pregnancy. In them, only 3 developed GDM and 99% did not develop GDM. This clearly shows more than 110 milligram. If you give metformin, that lady will not develop GDM. Finally, the detection and care of early distortion of glucose tolerance, if you do that, prevents that lady will not develop GDM, she will not become diabetes and NCD in all later years. So that's very important. This slide, how this is important in this study. Though the successful Chawla and Jaggi told, the successful outcome of this study establishes primordial prevention diabetes possible. That is title given this answer. Now we will finally methodology follow for diagnosis. In this again very important message, WHO guideline does not include A1C. A1C is not necessary for countries which cannot. We don't have equipment for this as a means of diagnosing diabetes in a pregnant. For scientific time and a public paper, you will do all those things. But in the field area, it is definitely not possible. You will see it was published in the DRCP. And here also, whereas we say suggested a simple point of care test, the glucometer, AccuCheck is the best meter at home or in the periphery for healthcare workers and in wellness centers. So this is my message for everybody here. So I would like to share with you what is happening here, and you must appreciate my age and work in this field. 1980, we started working in the diabetes and pregnancy service in the Institute of Obstetrics and Gynecology. And that time we published a paper. 1980 published venous plasma glucose more than 110 milligrams. This was published in the Foxy Journal. The next step, again, Louis Journal, she also 2006, fetal threshold 110. Again, it's published. Next study comes Hernandez, 2011, which I told you earlier, it came 110 milligram. NIH again 2018, A1C 110 milligram and blood sugar level. Again, I came back again once more with the Queerest study. We can prediction of GDM 110 milligram. What happened? Many people questioning me. We've all done it. What about Americans? You have to say Americans. Americans have come. They have said diabetes care 2020. This year, optimal mean glucose is less than 10 milligram for better fit outcome by continuous glucose monitoring. So now you definitely have to accept what I'm saying is your target of diagnosis will be less than 110 milligram, more than 10 milligram. Must very careful and treat them. So finally, categorization of glycemic, there some people have this doubt. GDM is a different matter here. The GDM is glucose based. It is 2 over PG more than 20 milligrams. It is glucose. It is not by meal. Whereas our test are GG girl, you will have seen one number, 119. This again, that is meal. Here you see gestation glucose intolerance, 2 more than 20 milligram to 140. That is called gestation glucose. What we are, you don't worry about this. This what our talk is eggy. So here, early gestational glucose intolerance. I never said gestational diabetes mellitus. I want to use this word only. Early gestational glucose tolerance, 10th week. Parental base 2 ppg, 110 to less than 19. A normal glycemia in prandial will be 2 pg, 99 plus or minus. So all the mantra 110, Yagi 110, anything above 110 is a problem. So finally, this is a message. This time I talk. Prediction of GDM, 2 ppg, more than 10, between 110 and 19 at 10th week of pregnancy. And then for here, preventive action has to be taken at the 8th week so that maternal PPBS remains less than 100 milligram throughout pregnancy. Intervention MNT, metformin to continue until confinement, follow up with a signal after delivery. So these are very important messages. Now aim to maintain when you're treating a person from consumption to confinement, this is what you should do. The 2 PPG should be this value, 99 to 909. And then 2 PPBs at 8th week green, 10th week is very good, only because the people will come to the clinic. 10th week, no problem, no use, because not necessary, metformin won't be useful, so do whatever you want. But after that, you can follow them with 12th, 24th week, with use, we can use the DIPSY guidelines. So the very crux of the problem is maintain the blood sugar 99, 109 from consumption from 8th week to the delivery. So friends, here, sequence of events in weeks. 10th week, prediction of GDM. Every week is very important. Prediction of GDM. And then 8th week, screening in anticipation itself. And about 11th week, fetal precursor starts insulin secretion. And 12th week is a no use. No use. Treatment not effective. So these three numbers are important. 10th, 8th and 11th. These three numbers. Most important will be 10th and week. About 8th week will be helpful to us to do what we should do. So finally, diabetes-free generations. For diabetes-free generations, 2 ppbs should be maintained all the time on 10 milligram. That should be a target. I told number of studies showed preconception period, pregnancy period, or postpartum. All these things will only 110 milligrams, should not be crossing it. So finally, this is my suggestion, decoding GDM. I leave it to you, audience here, early GDM. My concept is here, early GDM must goes to EGI, early gestation glucose tolerance. This is because here EGDM versus EGI, early gestation glucose tolerance. That's what I'm doing. Early gestation glucose tolerance, green. Early GDM is correct, but I will still say here, early gestational diabetes mellitus. What happens here versus early gestational glucose? You'll see the name. There's no diabetes word will be there. So suppose it happened. This 2014 Government of India guidelines came. That is the time what happened. One of the officers' daughter developed diabetes, the GDM. So that when it tells GDM, they get panicky. The word diabetes comes into that panicky. So that is why I am suggesting here, particularly in the northern people, they don't want daughter-in-law or daughter, somebody tells, oh, your daughter has developed diabetes. They say diabetes. God knows how they treat their daughter-in-laws. That's what I have seen the papers. That's why we don't want that word here. Early gestational diabetes mellitus has physiological, psychological impact on women and family. Hence, we suggest a new term, early gestational glucose tolerance, because all the time by 10th, 8th week, 10th week itself, you will finish all the tests possible. So this what from the publication of that we came to the terminology itself, early gestational glucose tolerance, that is decoding system. Hence, finally, hyperglycemia pregnancy is urgent. It has to be done. And then important also, and it's very simple, one test, 2 ppg, one value, 110 milligram of blood glucose. That's all. This is my talk for 20 minutes. Finally, I said decoding. Now I'm coming here prioritizing. By prioritizing women's health and implementing evidence-based strategies for GDM prevention and management, we can pave the way for a brighter and healthier future. And I'm sure our government of Jitendra Singh told in a meeting, hope and scope for diabetes-free generation 2047. Hope the government of India accept the concept and start working on this area. So, friends, ladies and gentlemen, I'm very happy for giving me opportunity to talk to you people. Hope I given my ideas based on everything on science. Thank you very much for listening to me. Thank you very much.
Thank you, sir, for an excellent oration and a very exhaustive review on primordial prevention, which was hypothesized by you 5 or 7 years or 10 years ago. And good thing is that in your own lifetime, there is a lot of evidence now. It is getting proved. Not only proved, it is also getting accepted gradually
Yes, sir.
in national meetings also. And I'm sure IDPSG, when we have next year an international meeting, maybe this topic might be highlighted there also. We have actually requested them to keep this topic in the international conference also. Dr. Hema has been logging up in many meeting IDPSG. So we have been working hard on this concept, and I'm sure sooner this concept might also be adopted internationally also. So with that, we go to the third session. Dr. Hema, will you swap with sir and in the end, or you have to leave and
Then you want me to speak next?
no, otherwise I thought that let Dr. Sujata and then Bhavtarni and you come in the last. What do you say? Or you have to leave, then we can.
Yeah, because I
Okay.
think 5:30 I have a
I know
meeting,
because
but
I
I can come
requested
back again if you want.
sir
But
was not well,
yeah,
so
yeah.
okay. So even in fact, Dr. Sujata is also saying that I have a meeting at 6 p.m. with the government officials. So what we'll do, we will tell Dr. Bhavdharni to take the last session. So we may proceed with Dr. Hema's session. And what she is going to talk about is preconception counseling and postpartum follow-up. And for that, we have the wonderful speaker, none other than Dr. Hema Divakar. She's a gynecologist, obstetrician, speaker, and activist. Currently holds an exhaustive list of important positions both nationally and internationally in Asia and IDPSG and FemDep also. She's a speaker and activist, technical advisor to Ministry of uh, India Family Welfare, chairman of FIGO Well Women Healthcare Committee, dean of Karnataka College of Obstetricians and Gynecologist, and president of FOXY. Over to you, Dr. Hema, please.
Thank you very much. And it's my pleasure really being here because this connects, brings in so much richness. The rich feeling is because of unconditional blessings from none other than Professor Sheshaya, our father figure, and of course, a very beloved and affectionate connect with Rajiv ji, Shalini ji, of course, Bhavtarni, Samir Das, Sujata, Sunil Gupta, Anuj Maheshwari, and the family list continues in a bigger and broader way as a ripple effect. As OBGYNs, Sujata will agree with me that are in double trouble because we are dealing with two people at a time, the mother and the fetus. Beyond that, we are dealing with two families because I'm to speak about pre and post delivery. Okay, that time the families, it's up to them. The mother in law and the husband side family may say something quite in contrast to the cultural and socioeconomic background of the patient's family herself. So that's again another challenge for us to balance between the two. And needless to say, the two groups of specialists are here, the diabetologists and OBGYNs who may agree to disagree on many points, and more to come because there's a dietitian and the neonatologist also. So amidst all these challenges, how do we deal beyond the realm of the limited edition, as I call it? The pregnancy phase is the 9 months, but there is a before and beyond. So this wheel that you see here, launched in Paris 2 years ago by our Committee of Well Women Healthcare Advice, depicts what is the life course approach. And Sir has just spoken about a very, very valid point. Be ready and tackle it even before it starts to bloom. You need to sharpen your mind, and therefore you'll see on this wheel that at every point in her life, she needs to be aware, she needs to be cautious, she needs to be prepared in readiness for the next phase of her life. So also, the preconception and the postpartum are equally. Sir said it's urgent, it's important, everything applies to the topic that I'm going to be deliberating about. So the FIGO also brought out a preconceptional care paper, which said making difference both for the mother and the baby. It was a very powerful figure position paper who said that it's not enough if you do a lot of things in pregnancy. You had the time, you had the opportunity before, just like Eggy was displayed to us now. There is a time frame where you could get into action. It is indeed a window of opportunity, the preconceptional period. It's unique, though we grumble as OBGYNs that these women preconception are never available to us. But many a times, it's not always before her first pregnancy, but before her second pregnancy, that is inter-pregnancy interval. We cannot make any excuses. Once she gets into trouble in her first pregnancy, it's our duty to track her in the inter-pregnancy before she gets on to the other pregnancy. So that's preconceptional for the second pregnancy. Now there's a huge program by the government itself about the adolescent care and the preconceptional care. Sampurna is a program launched by Foxy President Dr. Sunita Tandulwalkar, which entirely talks about the preconception care. And we are collaborating with FIGO as well on the Foxy FIGO Sampurna initiative, where Well Women Healthcare in the preconception period has to become a reality and not just be talked about. So the FIGO preconceptual care checklist. In FIGO, we love the FIGO boxes, which brings and highlights to our attention what the whole article says. And there are also several checklists because OBGYNs are very busy. Paramedicals can be taught to just tick the checklist, and there's a lot we can gain from shifting the task to them so that nothing is missed out. So this checklist essentially speaks initially about the baseline data, and then the prime segment of nutrition, which is so very relevant to the glycemic status of any individual. Think nutrition first is what the FIGO says, preconceptional and in conception and beyond. The third point is about supplementation, the folic acid, as we all very well know, and maybe now we may need to get some other supplements on board to see that the appropriateness of the preconceptional optimization is maintained, the lifestyle variables and the vaccines which need to be in place. So the nutrition is a big piece, and there is a FIGO nutrition checklist on which are structured. It just takes less than 2 minutes. We just have to train our paramedics to just ask what food groups, how often, what is the portion. They get a very quick, clear idea, which they flag it off to the consultants, and then we can focus on the further advice. Needless to say that the social media has really brought the folic acid concept into the girls and women. So they are, truly walking the talk of your care is in your hands. And in this era of the H3N1, I believe, is an outbreak in Delhi. The flu vaccine, we just did a major program. Flu vaccine liye kya was the title of the program. So there are so many things that she needs to take during pregnancy. Maternal immunization also is a matter. The preconceptional checklist then goes on to say in the inter-pregnancy interval, some data to be collected and the pre-existing medical conditions. Some she may not know, some she may know, but we may not have the time to ask because we are focusing entirely on our branch. But the inclusive of cardiovascular, respiratory, already pre-existing diabetes, which she may know, and she has not revealed it to us, again, because of the two family things, even epilepsy and that. They want to keep it under wraps. They don't want. Professor Shesha just mentioned that how they may treat their daughter-in-law if they know that she is a diabetic. So it may just be not revealed unless it is very, very confidential kind of an information. And many going into the state of mental ill-being and depression. So all of these need to be checked. So going back to the very prime point that we necessarily, just like the blood group, RH typing, height, weight, BMI, we always now include the nutritional checklist into our armamentarium of practice, both preconceptional and during early phase of pregnancy. Identify the special diet needs, because a South Indian, you ask them, if you don't ask them whether they're vegetarian or not, and you start quizzing them with question how many times you eat fish, meat, etc., it'll be a clearly, they stand back in the initial part of the dialogue itself. So the first is the basic and just the type of food that they would eat, and then calculate the BMI. The third is, as we said, this in 8 different Indian languages. We have trained many paramedics to do this in their own settings, and some pictures are given about all these food groups and the grades, which they can easily relate to, and they can give us a fair idea of where we are going with the nutrition, and also the micronutrient status, the multiple micronutrient supplements, which the government is yet to bring along, folic acid, vitamin D, and all of these histories is taken. This is the era of technology, and we cannot but help say that you may be busy, do the 2-minute Figo nutrition checklist, extend to the apps which may give them a particular guidance about the recipes and the calories as well. So optimizing the nutrition and weight to keep the glycemic level, and the complications in the early part of the pregnancy, disruptions, miscarriage, malformations, very important in the preconceptional stage. And all the respondents agreed that extending our consulting to the digital platform is of immense value indeed. FIGO has also brought out a FIGO pregnancy passport because, as we said, just the preconception is not enough. Just look at what we say. Yes, she delivers today, all well, she's discharged, where we note down whether her blood pressure was normal, whether body mass index was normal, whether the glycemic status was normal, etc. And the follow-up checks at 6 weeks, 3 months, 6 months, 12 months, and once a year. So all of these, including the advice on breastfeeding and the weight reduction, has to be given postnatal, and the baby's information, because as one of our very close associates and colleagues, Dr. Anil Kapoor from the World Diabetic Foundation would say, use the vaccination visits to also empower the mother, but also tell your pediatrician that this baby is born out of a woman with hyperglycemia in pregnancy, and there's a lot more for them to do as well. So a lot of these are in the checklist, very easy to do, and the pregnancy passport. Furthermore, long-term impact of preeclampsia, gestational hypertension, gestational diabetes, preterm births, and other things, which may lead into 4 times more the comorbidity of blood pressure, twice as cardiovascular disorders, twice as much incidence of strokes, 3 times incidence of diabetes type 2 further on in their life, kidney disease, venous thrombosis, you name it and you have it. So all of these have to be kept in our mind for long-term care, and we need to counsel the patient. What can you do to reduce such risks? Just simple walking and exercises 150 minutes per week. Breastfeed as long as possible, because that in itself will get your weight reduction and also your chances of getting type 2 diabetes will come down by 57%. Aim to have the best of the body weight. Get at least 6 hours of sleep, because that could be very distressing. Eat a diverse diet which is rich in colorful fruits, vegetables, including nuts and seeds. So this diet advice continues even after delivery, and see your primary care provider. Even if they don't have specialists in smaller towns, they can always connect on the teleconsult, and suitable options for contraception for at least 2 years beyond the first pregnancy. So, what can you do to reduce such risks? Because just giving them the information about the risks and getting them scared is not the correct way to deal with. They will need to check and help themselves with all these points which you've said. And also, we give them guidance on the health checkups and the tests when they have to report, what we will be doing with them. So they know that they have to be a little more cautious and much more serious about their well being for the rest of their lives as well. And as we often say, GDM today is NCD tomorrow. Those children with early onset obesity and early adulthood diabetes also need to be kept in mind. The fourth trimester, which is often overlooked in traditional maternal care, the importance of holistic care. It's not only the physical recovery, the emotional well being, because stress can multiply the internal environment to never let her glycemic status touch normal, the kind of help she may require for infant care and the family support. The postpartum depression is a reality, so postpartum care, especially because first time it's been revealed to her that she has high blood sugar, maybe high blood pressure. These come as a shock to her, much more than what we can imagine. Especially, you explain to her the long term consequences, and she asks, why all this and why me? So these are the kind of mental stressful situations which need to be tackled again by hundreds of counselors whom we are creating as a special cadre to just take the primary consultation. Just lend her your support in terms of time and reassurance. Just give her some time to just express herself. And if you notice something, flag it off to the next level of consultation. This has been a great game changer because sometimes they have very minor problem, but nobody to listen to. It just blows up into a big risk for their mental well-being altogether. Many opportunities for community and network support and remote counseling, because they never like to enter into a counselor or a psychiatrist chamber because they're always looking here and there. There may be somebody else who known to them who will come into the same premises and notice, hey, why are you here? What's wrong with you? So anonymity and confidentiality, very important. Again, the FIGO emphasizes that pregnancy offers a window of opportunity to establish this continuum of services from preconception, then hyperglycemia in pregnancy care, move on to the long term postpartum care, early detection, the supporting, the advice in pregnancy and beyond, retesting of all these at 6 to 12 weeks and beyond. And there are certain other developments that even before she gets discharged, if she's tested, it is a wise thing to do because it almost taps into what the probable glycemic status of this woman could be, because she may not turn up at 6 weeks, she may not turn up at 12 weeks, then you have missed the opportunity of alerting her. Then the further glucose test, how she needs to do. So these are many centers in remote villages that we are tackling, because the point of care devices, the glucometers, which first all started with Tamil Nadu, with the government giving these glucometers at every nook and corner, and everybody learned how to do it. Now every household has it almost. So everybody is familiar with this. So they cannot say that we are going back to our villages or remote places and therefore we cannot have the glucose tested. There are support groups well within the community and these tests are possible. So if you speak with conviction and emphasize that this is the need, they will be careful and follow the instructions. I'm quite sure. And then we are always available to them on the teleconsult. So this is a very famous slide within the DIPSI group as well, because the opportunities to minimize the risk of NCDs should never be lost. And you see the mother and infant combination. That means we as OBGYNs primarily can do our best to keep the NCDs at the lowest level. Miss that, then the pediatrician, adolescent and childhood, there again, then adulthood. And if you have no intervention whatsoever, you just ignore the preconception and post-delivery phase, then you see how the risks of NCDs, millions that Sir spoke about, Yes, it is going to be a reality. And if you want to hope and scope for 2047, a diabetes free country, then the action should be most impactful at the level of the combo of mother and child. So, we as obstetrician also believe, we are boasting that maternal deaths, infant mortality has steeply declined in our country. And the rate of the decline, dear friends, is the fastest in the entire globe. That way, we have done well for ourselves. Obstetric emergencies are being timely attended to, and today we are dealing with the tsunami of NCDs, and tomorrow the same mothers whom we have helped them survive, helping mothers survive, a great project. Okay, now mothers are surviving, but getting into diabetes, hypertension, landing up with cardiovascular accidents, hypertensive disorders, and whatnot. And that is not the quality of life we want for our mothers. So please, let's just focus on before and beyond pregnancy and address these issues with all our might and sincerity, so that every girl, every woman, everywhere, every time knows what she should do for herself. And if the community is empowered, I have no doubt that if we all put our acts together, the hope and scope will become from dream to reality. Namaskar.
Thank you.
Thank you very, very much for
Thank
this
you, Dr.
wonderful
Hema, for a
opportunity.
wonderful, very pictorial and awesome oration as always.
Thank you.
You are an expert in making any presentation. I'm so fond of your presentation.
Thank you,
Excellent.
Rajivji.
Thank
Kind of you to say
thank
so. Thank you.
Thank you very much. With that, we go to the next presentation, that is by Dr. Sujata Mishra. She is going to talk about antenatal monitoring in women with HIV. Over to you, Dr. Mishra. Dr. Mishra, she is a director, Postgraduate Institute of Medical Sciences and Research, Bhubaneswar, Odisha, Professor, Department of Obs and Gynae. She is President, Association of Statistician and Gynecologist 2026, Vice President, FOXY 2015, Chairperson, FOXY Medical Disorders in Pregnancy Committee 2009 to 12, and Secretary, Association of Obs and Gynecology, Odisha 2012 to 14. Has huge number of publication, and I can promise you she is again a very wonderful orator. Dr. Mishra, please. Over to you, madam.
Thank you, Dr. Rajiv Chawla, Dr. Shalini Jaggi, for having me. Thank you for those words of introduction. I'm a part of you all. My regards to all my friends over here, Dr. Bhavtarini, Dr. Hema, Dr. Samar, and of course my special allegiance to Professor Seshia. So on the slides, I just shared them. Yeah, that's it. Is it okay? I'll just
Yeah.
slideshow.
Put it
Yeah.
in slideshow.
No, I'm just doing that. Yeah. So yes. So without any formalities from it, and this is to be honest, I would wish to theoretical and it is practical what is doing to reach out to as much as possible and to translate all our thoughts into actions and let them not stay in textbooks or various, as such. So I was told to talk on antenatal monitoring in pregnancy. Now, first things first, we all know that pregnancy is a state of resistance. What resistance? Physiological insulin resistance. Every lady who gets pregnant is insulin resistance. We are just lucky that our pancreas behave themselves and they're well disciplined and we do not become diabetic. Now, why is this so? Because what happens is during pregnancy, the insulin-mediated glucose disposal in every lady is supposed to decrease by approximately 50%, and your insulin secretion to compensate that increases by 200 to 250%. Hence, if your beta cells are efficient, you will still remain euglycemic. And why all this happens is because the glucose as such needs to go to the baby. On that background, I will start on what all should we do in the antenatal monitoring. When we talk of antenatal monitoring, we focus on managing the blood glucose levels, on monitoring fetal
Excuse me,
development.
ma'am. Your slides are not moving and your audio is not clear.
It's not clear.
Yeah.
I've gone to the second slide. Is it okay? No?
No, no, ma'am. Your slides is not moving.
Put it in slideshow mode once again.
Yeah, it is on slideshow.
Then you may unshare once and then share again.
Okay, okay, let me do it once more. Sorry. Unshare kar do, close kar de lo. Let me share it once more. Yeah. 1 second. It's a Is it okay now or no?
Yeah.
1 second,
Now
1
share
second.
the
I can
slides.
just see Dr. Rajiv.
Share the slides.
Yeah, just going to it.
Slideshow mode.
One interesting. Jani ji. Is it okay? Otherwise, I don't know what I'm going to do.
So sometimes it never comes. So we can leave it, I think.
No. How can that be possible?
No.
but
Sometimes
can
it
you-
happens. So you
Can
try.
you move the slide? Yeah.
You want me to?
Is
Abhi
it in slideshow mode at your end?
Yeah, it's totally in slideshow. Let me stop share again. ठीक है ना?
Then, ma'am, yes, you can stop and share again.
I have stopped
Yeah, that
sharing. Just a waste of time, no? So it's not coming through. हाँ, अभी share फिर से करते हैं. Is that okay? No?
Yes, now you put in slideshow mode.
Yeah, now I'm going. Is this visible? I mean, that was the question.
Yes. Now you do
Ma'am,
it.
ma'am, you just select the second. You see there is a you when you are sharing at that time you see there is a window of presentation sharing. Just select this.
Yeah, let me see again.
Yeah.
They have some 2-3 windows. Let me see. Which window?
You see there is a PowerPoint window is there in your Zoom. Yeah, just select that.
Select that. I did that now. ये वाला. Okay. ये वाला करके.
Yes.
Yeah. Now
Okay.
it is.
Let
Now
me
it
Now
is
you can
there.
move.
Yes.
So should I share this? I've already shared it. ठीक है?
Just move one slide and you'll come to know.
Okay. नहीं क्या होने. One second. Hang on. इसको देखते हैं. No, that's not going at all. Yeah. Is it okay?
Yes, it is. Yes, it is, well.
Done. अच्छा ठीक है. करो फिर next.
Yeah,
Is it
yeah.
okay now? So I've got
Yeah.
somebody doing it for me. Okay, fine. So now it decreases to 50. Slide that distant. So in anti focus on managing.
Ma'am, speak closer to mic.
Actually, other fetal surveillance methods. And can we
Ma'am, your voice is not coming.
The slides are moving now. Your voice is little breaking.
No, I don't think I can that. So I can go into the slides. So let Bhavsarni speak. Was I visible? I mean, audible first. I mean, I don't know.
You need to share again. Yeah.
Slide share kar do
Yes.
na.
Put it in
I'll share.
slideshow now.
Yeah, just doing it. Yeah, but am I audible?
Yeah, you are audible.
So I'll go to.
But ma'am, your slide will be not moving because what you do is you open the presentation and do the slideshow. That's why it's not coming. First do slideshow, then do this. Then sharing.
Share. They want the presentation closed. Okay. देखो काम कर लो बंद कर दिया आपको nice. I want to close this. Close कर दिया. They want me to go from the first slide. Should I start from here now?
Yeah, you may start, madam.
So, so if you slide show something was wrong. Now, is it going to slide? Is it going?
Just share, ma'am.
Huh?
Just share the share.
I have shared. अब इससे
No.
ज़्यादा I cannot do anything. करो.
Stop share करके मैम please share
एक
again.
second. This is the last time I think I'm doing it. इसको करो फिर से share करते ही चलो.
Or you may email it to RX people and
Yeah, I'll do that while he's doing it. I'll mail it. I have it in my phone. I'll mail it right away.
you may, yeah.
I have it in my
And
phone.
they may,
ठीक
yeah.
है, ठीक है, ठीक है. आया अभी आया? Is it okay now?
Ma'am, put it in slideshow mode.
मेरे
Slideshow
सारे में
आया.
slideshow में है. Slideshow में है. वैसे दिख रहा था वैसे देख लो आप तो. Is it okay or what do I do?
You may share the slides on
Just give me
WhatsApp
2
or
minutes.
mail, and they will run from there, and that will be better.
Okay, I'll do that right away. Sorry,
Neelam,
Bhavtarini.
Neelam, you are there or who is there? RX, who is
पटेल
handling?
नहीं. But this usually doesn't happen. Why is it happening?
I don't know.
Say it to who, China. Why isn't it going? I'll just set it with the RX people. Dr. Chawla, can I send it to you?
Yeah.
So
Okay.
then what we can do is we can have Dr. Bhavtarini's presentation first
I
and then
understand,
we'll save
but
time.
we have an
Yes.
issue. Okay, I've sent it to Dr. Chawla already. Because I have a meeting at 6. That was the only thing, nothing else. I'm
Okay.
अभी sharing हो रहा है ना पूरा. So
मैम
अभी
आप
तो पूरा
stop
हो रहा है.
share करो अभी.
मैं 2-3 बार कर चुकी हूँ shop sharing हूँ.
Because your screen is now if you want एक बार आप try कर लो share करके.
Last है ना. चलो ये वाला ठीक है.
Yes.
अभी screen
Now we
sharing
can
कहाँ है?
see.
Yeah. Can
अभी
you
let me
move
see
it once?
पीछे जाऊँ कि नहीं आगे.
Yes, ma'am. आ गया.
आ
Yes.
गया.
Now it is moving.
It is moving now. Yeah.
Okay. So I finished the slide. So we're going to focus on managing blood and look at fetal development, ultrasounds, management includes lifestyle advice, medication, and close monitoring for adverse pregnancy outcomes. Specifically, antenatal monitoring techniques such as fetal counts, stress tests, and biophysical profile of normal results guide further intervention. So when we talk of monitoring of the and short-term complications. We are also looking at long-term risks of type 2 developing type 2 diabetes and other cardiometabolic disorders in the child. Now, there are certain maternal issues. Dr. seen this slide when we last met recently. So, in this, look at how the insulin response as you go from first to second to third trimester, and proportionately your complications can be. So, there should be regular visits of institutions, endocrinologists, nutrition, and physical instructors. At each antenatal visit, evaluate for hypertension, protein, the which you see are all the gradations given by ICMG. First antenatal in about 16 to 20 weeks, and at 28 weeks, when it is diabetic retinopathy, clarify the of so like hypoglycemia. What if she just has had she's a case of PGD, she had cysts. Cases and everything. But we should do infection surveillance in all. Somehow, the observation of association of hyperthyroid with GD and diabetes, both pre-GD. So we should look at TSH, and as government rules and regulations, we are screening for research in the first trimester. ICOG also says that we should give aspirin 150 milligrams actually right from different, so this is a personal decision. Started over indicated. Glycemic control. Optimize glycemic control in HIP reduces the risk of preeclampsia and then reduces. Actually, what happens in cases of G complications as such related to the it is going to do and and so in lifestyle changes, activity and exercise. If sugars remain uncontrolled, insulin or metformin can be added. Somebody else is going to speak of pharmacotherapy, so I would like to talk much about it. Dr. Samar and Professor Sishya talking about the needs of blood glucose. Sure, here may be a little different because that's as per the guidelines. And what Professor Sishya has shown is what we are aiming for diabetes in the future. So about 30 minutes of moderate intensity aerobic exercise at least 5 days a week or 50 minutes is required. Healthy diet with carbohydrates limited to 35 to 45% of calories. With sugar profile, there's often a discussion as to how we should measure blood sugar. All the idea is SMG. To do this idea should have at least one pair of only and value. But this is possible every find whether the frequency of which you do it. HbA1c is useful during pregnancy due to a high turnover of RBC during pregnancy and these. What I would further like to say is discussions we saw levels of HbA1c. Dr. Seshia showed us at 5.3. Dr. Samar also said we should be less than 6. When done, this basically helps us in cases of people who you see for the first time high sugar values. Symptoms. Now we'll talk of certain special cases because we are if a lady who is GD or gestational insulin drugs are not, she lines up with preterm labor. Corticosteroids. Now, antenatal corticosteroids must be given. Issue is when drugs, the blood sugars are going to plummet high. That does not keep drug because for lung maturity because you plan it. So in these cases, these drugs for lung maturity, if you think level and insulin dosages, because these spikes in blood glucose are the ones which are to the fetal decrease. Additionally, you can give tocolytics different choice. Although the use of corticosteroids is advocated in early preterm labor, but in gestation, so after 34 weeks, we give it. Macrosomia. Cases end up macrosomia. What is macrosomia for us in India and what is in Western countries? 5 kgs or 4,000 to 4,500 grams as macrosomia, but we will get 3,450 and above. Ultrasonography is an effective tool. Controlling it and strength exercises are recommended. Patients, of course, preconception counseling is always to ask them to go for surgical, intervention if indicated. So in the process of doing an antenatal monitoring, to give certain advice. One advice be how much of carbohydrates you can take, how much of fats. When you tell her you take MMP for she's got to follow Dr. Sishia because some said that if you look at something between so carbohydrates, women would be doing would consume to 45% of the total calorie intake distributed into three foods. Complex carbohydrate from milk, food, and non-starchy vegetables, whole fruits, dairy products, whole pulses are welcome. Sprouts and whole grain cereals and oats and millets also are recommended. Snacks could be fruits, clear soups, and sorted vegetables. Now, if you look at fat, women reduce the fat intake that goes without saying, and there are various ways to you can alternate to take so to take less fat in cooking, avoid fried foods. The protein requirement would be 1.5 kg per fetal. Source of protein in the sprouts, egg, and of course fibers. So when you therapy at carbohydrates and how much you can take. Fibers. Actually, which can be built by eating 400 grams of colored non-starchy vegetables and 200 grams of fruits every day. Issues become to certain issues. And this is just a bird's eye view of all these complications that can come.
Dr. Mishra, you may switch off video. That will improve your audio.
I'll switch off the video. Okay.
Your video you may switch off.
Okay.
So that will improve your audio. Bandwidth at your end is little less. Yeah, now you may continue. Yeah.
Okay. I'm sorry.
Your audio is not clear, ma'am.
I think let me round that slide then. Okay. I don't think they can hear.
Please continue, madam.
We can't hear you, ma'am.
Okay, then you can just see this. The doctor studies are recommended stress test and biophysical performance. Especially that you should study local practices. Feeding surveillance should but ideally it should be between 6 days. It's not that just because she is a diabetic. And with that slide, I'm sorry, because it's not working out.
We are extremely sorry for this technical. I think there is some problem with your internet width there and your signal at.
You know, मैं तो सारा सुन पा रही थी actually. I don't know what went wrong.
I know, but maybe you're in an auditorium and there is some echo effect also coming and yeah, doesn't matter. I think still thanks a lot for your presentation and I'm sorry for the technical issues which happened in between. So with that, we go to the last session by Dr. Bhavtarni.
Yes,
I think
sir.
she, yeah.
Yes,
Dr.
I'm
Bhav-
ready.
Yeah.
Pandra.
Yeah. Dr. Bhavdharni, she's FRCP and she's director at SRC Diabetes Care Center, Erode, Secretary Tamil Nadu RSSDA chapter, State Coordinator for Diabetes IMA FCD course, Joint Secretary DIPSI, Honorary Professor of Diabetology, Wonka, and Academic Excellence Award she received by State IMA, and she also received Best Teacher Award by State IMA, Tamil Nadu State IMA Teaching Center. Our center is a state accredited center for training in diabetes. She is founder and ex committee member, Tamil Nadu RSSD, TEPICON, DIFSI, and DFSI, and past API secretary, Erode Chapter 2008. She was the organizing chairman, Track 2018, and advisory board member, COVID and diabetes guidelines, Tamil Nadu government. Over to you, Dr. Aftar.
So is my slides visible?
Yeah.
Thank you, Dr. Rajiv and Shalini. Very good evening to one and all. And pranams to my mentor, Godfather, Professor Dr. Seshia. Very happy to be with the siblings of Dipsy today. I'm very happy coming to the topic as such, that is management of hip in 25. Of course, management, it includes the proper diagnosis and appropriate treatment. And banding in 1980, he said it is only type 1 passing through pregnancy as far as the diabetes is concerned. And then we had the gestational diabetes. But now there is a paradigm shift because of our lifestyle, improper lifestyle. We do have type 2 diabetes, prevalent GDM, that is diabetes detected for the first time during pregnancy. And of course, incident GDM, we do get all this in pregnancy. So the management differs. This incident is not equal to prevalent, and the visit differs according to the blood sugar. Glycemic goals differ. There is different fasting and postprandial, different HbA1c, different meal plan, different hemoglobin percentage, different BP and pulse, and different treatment regimes. The time and range differs, and also the different insulin requirement. So we need to know in depth about the pathogenesis of all. We know that it's a physiological phenomenon that every pregnant woman do undergo all these hormonal changes, the diabetogenic stress. But if she happens to be normal, she secretes adequate insulin to overcome all this and keeps blood sugar under normal. Whereas if you take the pathogenesis presently, what I said, the paradigm shift, most of the women are insulin resistant with hyperinsulinemia. And this insulin, though it does not cross the placenta and enter the fetus, it has so much influence on the placenta, increasing its placental growth, increasing the angiogenesis, causing lipid droplets, and also via the GLUT1 and GLUT4, it transmit the glucose from the mother to the fetus, and here it stimulates the pancreatic beta cells and causes cardiohypertrophy, cardiovascular disease later in life, fetal fat deposition, and early obesity, and later in life beta cell exhaustion and leading to type 2 diabetes, and impaired hypothalamo development leads to effects on feeding behavior. So all these are features of hyperinsulinemia, which is initially from the mother, and as our professor mentor and all previous speakers talked, it is taken over by the fetus by 11th week of pregnancy. So it is nothing but the maternal hyperglycemia and fetal hyperinsulinemia are the kingpins of pregnancy metabolism. And remember, this fetal hyperinsulinemia not only causes GDM and later diabetes, but also all these problems: dysglycemia, hypertension, generalized obesity, abdominal obesity, hypercholesterolemia, high LDL cholesterol, low HDL, all this happens. Now, coming to the point, in the management, why to screen, whom to screen, when to screen, and how to screen. Of course, why treat it is like eating 2 mangoes in a single shot. We are taking care of both the mother herself as well as the baby, and prevent her from all non-communicable diseases in the future. And you know about the maternal risk, heard about from my previous speakers about the maternal risk, fetal risk. All this happens because of GDM. To prevent all this, we need to treat. And coming to whom to screen, of course, it is universal. Indians are 11 times more prone. We are more insulin resistant. And nowadays, it's a day of late marriage, further delaying the children, single child, more of infertility. So every pregnancy is precious. So don't wait for any risk factors. And when at the earliest, either preconceptionally or in the first visit, it's why? Because if you take, as I said, there is a shift. It is not the only type 1 passing. It's all diabetes detected. Pre-GDM is very common nowadays. So it starts, it's present right from the embryogenesis. So you have to screen at the earliest, whereas GDM occurs later. That's all different story. But we need to screen in the very first. And also the congenital anomalies are over by 8 weeks. If you fail to screen in this early weeks, you are going to land up in some congenital anomalies. Then you are going to screen in the next pregnancy only. And again, our mentor, he has done a study irrespective of the trimester. He has screened all the pregnant women and he has found there is prevalence of GDM 16% in the first, 22 in the second, and of course more in the 61. This is in 2007. And if you're not doing in the first and second trimester, you're going to miss almost half the cases. And he has repeated the same in almost 11,755 cases later after 10 years. And what he has found is it has doubled in the first trimester, and also in the second it has come down in the third trimester. So it clearly insists that we need to screen early. And again, the fetal pancreas starts functioning by 11th week. If you delay the screening, we are going to miss the diagnosis and we'll get false negative GDM. And how to screen, of course, with a very simple procedure given by our national guidelines: 75 grams of glucose in the fasting or non-fasting state, and 2 hours if it is 140 or more, it is GDM. And if it is negative, you have to repeat in the second and third trimesters, and always maintain the fasting and all pre-meal less than 90, and 2-hour postprandial all meal less than 120. Mostly the postprandial abnormality occurs, and if it happens to be more than 120, put them on mixture in the morning. And if it's still, in spite of increasing the dose, the fasting is not getting control, you have to put another dose in the night. And of course, you can go for plasma standardized glucometer as given by our national guidelines. And coming to the management, 90% of the women are managed with medical nutrition therapy and exercise, because it's all due to insulin resistance because of the improper lifestyle. Try this for 2 weeks. If it is not getting control, think about adding insulin if it is very much high. Coming to the medical nutrition therapy, the food plan is individualized. It is not the same for all, and it should provide adequate calorie intake to promote the fetal, neonatal, and maternal health, at the same time achieving the glycemic goals. Both under nutrition and over nutrition has to be corrected. See, here you are able to concentrate on malnutrition, and here you have to reduce the calories and make your food and take only homemade food. Better to advise them the ADA plate model, half the plate full of vegetables and greens, and reduce the carb to quarter plate, and take equal amount of proteins. As our Dr. Sujata said, you have to increase the protein intake to 1.5 grams per kg. So better to equalize so that we are not having increase in blood sugar. Fasting and feasting both has to be avoided. And instead of taking 3 large meals, give some snacks in between. Split the same calories into equal 6 parts with a interval of 3 hours. And remember, you have to give more protein in the night because it's a prolonged fasting in the night. And regarding the sweeteners, acesulfame, aspartame, sucralose, neotame, stevia are allowed, but it does not allow saccharin, and all should be taken in moderation. And the very next thing, which is equally important, like diet, is exercise. It's very important. They can do anything: walking, swimming, bicycling, dancing, climbing the stairs, whatever they prefer. But remember, it is not adequate if they do in the morning or evening alone. It has to be done for 5 to 10 minutes after each meal, after breakfast, lunch, and dinner also. And coming to the pharmacotherapy, of course, if the blood sugar is very high, insulin is the treatment of choice. But we can think about adding oral drugs. I'll deal about that later. Coming to the insulin, first and foremost, foremost, you should know what are the insulins that can be used. All human insulins, the short acting, NPH, mixtures, all can be used, very well used during pregnancy. In the analogs, in the rapid acting, you can use aspart and lispro, but not glolucin. In ultra fast acting, fiastin is very close to the food absorption in pregnancy, and it's very much useful in pregnancy. And in the long acting, glargine should not be started. If they are already on glargine, it can be continued. And detamir and deglutec, of course, are allowed in pregnancy. In the premixed, you can use the biphasic premix analogs, mixtures, no mix and Humalog both, but not the co-formulation, the pre-Rhizodec. And as far as GDM is concerned, they'll be requiring some minimal amount of mixtures in the morning, or they may require 2 times split mix. Anything according to the rise in postprandial, you can go for 50-50 or 30-70. This is enough in GDM. Whereas if it happens to be pre-GDM, type 1 or type 2, you have to go for basal plus or basal bolus. Sometimes if the diabetes is much early, it requires more insulin. What ordered Langer said, it's appropriate to use the dose needed to achieve the normoglycemia without undue concern about giving too much insulin to our patients. Our main concern should be blood glucose target than the dose of insulin. And don't worry about hypoglycemia. Drury, he has seen about 100 cases of pregnancies with hypoglycemic coma, but without any untoward effects both for the mother and the baby. But remember, if you are putting the patient on insulin, you always should educate them on counsel about the thing, teach them the SMBG and prepare them and advice about all the device mismatch, syringes, storage techniques, injection site, hypoglycemia, how to conquer that, and stress management, all has to be taught. Regarding the site of injection, in the first trimester, it is the same. You can inject anywhere, that is in the lateral aspect of thigh or abdomen. And in the second, it's the same thing, or you can go to the lateral aspect if she is very anxious. Third, of course, they can pinch the skin and put it in the lateral aspect on, and use other sites like thigh. And in very brittle cases, type 1, where you're not able to get the control pump, insulin pump is the solution. Regarding the oral drugs, metformin is safe and effective treatment in women with it in pregnancy, starting from prepartum period. That is, if they are having PCODs or they need to reduce weight or treatment of infertility like that, and up till prevention of diabetes in the postpartum period. It has produced less maternal weight gain, less preterm delivery, no maternal hypoglycemia, less insulin requirement, reducing the hypertensive disorders, operative deliveries, future type 2 diabetes. And of course, it is very cheap, being oral therapy, and requires no vigorous monitoring and frequent hospital admissions. And it has got a very good compliance and acceptability. And again, in the fetus, it showed less macrosomia, neonatal hypoglycemia with few NICU admissions. And regarding metformin, as my mentor said, again, this is the only anti-diabetic which has been improved from conception to birth. Not only that, it also lowers the pregnancy-induced hypertension and also preeclampsia. But always remember the contraindications. It should not be used in fetus at risk of ischemic environment, including placental insufficiency, hypertension, twins, preeclampsias, and growth restriction. Glyburide, of course, at present situation, ADA and ACOG, it's not FDA recommended for treatment of GDM. And acarbose, it is in category B. It's not systemically absorbed to an appreciable extent. So transplantation passage should not be an issue. And other drugs like glyburide and other sulfonylurea, glitazones, gliptins are not allowed. And ACE, ARBs, if at all they are mineralocorticoid receptor antagonism, all has to be stopped, and they have to be shifted to M-dopa, labetalol, nibitapin, or clonidine. And statin, of course, it has to be stopped. Regarding the time of delivery, if it is controlled well with diet and exercise, you can prolong up till 39. If it is controlled by medications, there again, you can go up till 39 weeks. If it is very poorly controlled, you can plan early 36 to 38 weeks. or if it is abnormal, if you have any abnormal antepartum fetal testing, then you can even prepone to 34 to 36 weeks. And regarding peripartum management, maintain the insulin dose in such a manner to avoid maternal hyperglycemia, because it will produce fetal acidosis, neonatal asphyxia, and neonatal hypoglycemia also. And intrapartum, withhold the morning dose of insulin while planning induction or cesarean during early morning. Start on 5% dextrose, any dextrose containing infusion, 100 ml per hour. Start in a separate regular insulin infusion also in the rate of 0.5 units per hour. Hourly, monitor the blood glucose and adjust the infusion. And it should be always kept between 80 and 120, not low or not high. And when active labor begins, insulin infusion is used in pre-DCM GDM because it is under your control. In contrast, GDM may not require once the labor begins, that is the placenta starts to detach. But in non-diabetics, insulin has to be adjusted by monitoring the blood sugar. Usually it gets half. And other investigations like regular monitoring of the weight, blood pressure at every visit, and fundus has to be examined in pre-GDM for retinopathy and nephropathy, microalbuminuria every trimester. And as Madam said, ultrasound fetal measurements initially at 8 to 20 weeks and later after 26 weeks, every 2 to 3 weeks to know the growth of the baby. And of course, CGM may be useful in addition to blood glucose monitoring. This is the thing which is very useful nowadays in pregnancy. And here the time and range is very strict. We need a 24/7 round the clock control. As far as the GDM and type 2 is concerned, it should be more than 90% of the time it should be within range. Whereas in type 1, it can be just more than 70%. It has to be tighter. And it has to, in case if you're doing self-monitoring of blood glucose, it has to be done for all 3 means prior and after. And in pre-GDM, of course, glucose monitoring and targets vary. It has to be treated according to the blood sugar. Maybe very frequently we need to go. And in pregnancy, the HbA1c has to be maintained less than 6.5 in pre-GDM always. And attention, as I said earlier, to be paid to ARB, ACE inhibitors, and statin, and continuous eye examination and urine serum creatinine and ACR has to be measured. And of course, myoinositol is very useful, and probiotics, they improve the insulin sensitivity, and also you should supplement with folic acid. And to prevent thromboembolism, low dose aspirin has to be started at 12 to 16 weeks. This also reduces preeclampsia. The main thing is you have to take care of stress management also, because this chronic stress induces hypercortisolemia, which impairs the insulin sensitivity by producing more hepatic glucose and inhibiting the peripheral glucose uptake. And nowadays, the telehealth in combination with in-person visit for pregnant people with GDM can improve the outcomes compared with standard just in-person care alone. And always advise them to start breastfeeding early, because this has got a lasting favorable effects on maternal metabolism and whatever has happened because of GDM. And also it protects against the future diabetes risk, both in the baby as well as the mother. It reverses all the pregnancy adaptations which has occurred in GDM and resets the maternal metabolism. Follow-up postpartum care is very important. It is equal to antenatal care. Repeat at the time of discharge. They have done a study compared at doing at 6 weeks and at the time of discharge, they have found it to be equal. So do at the time of discharge and also at 6 weeks, 6 months, and every birthday of the baby. But the targets differ. Fasting, if it is less than 100, that's adequate. And postprandial, if it is 140, it is impaired glucose tolerance. And advice regarding the contraceptives and preparing for the next pregnancy, she has to prepare herself for fit to conceive. And regarding the use of steroids, it's very useful, but always remember, as Sujata madam said, they can even go for DKA and the blood sugar rises like anything during these 3-4 days. So in the first day, when you are giving the first dose, increase the split into basal bolus and increase the night dose alone by 40%. And on the second day, give the second dose and increase all doses by 40%. Continue the increment of 40% third day also, and reduce it to 20% on the fourth day, then 10%, then it can revert back to normal. You monitor and adjust the doses. What I want to convey, GDM is such an important thing. It is the mother of all non-communicable diseases. So we are observing this, celebrating this GDM Awareness Day on every March 10th to protect the future generation and have a diabetes-free generation. So we first to grab diabetes NCDs, not only diabetes, all NCDs from its roots. We need to focus on the fetus for the future. Thank you for the wonderful opportunity, both Shalini and Dr. Rajiv.
Thank you, Dr. Avthani, for a wonderful talk. Over to Dr. Shalini.
Thank you so much, ma'am. I can see Dr. Sujata Mishra, ma'am, is also logged in. So thank you very much. I think we've started with the primordial prevention. We talked about early GDM. And then, we've heard the FIGO stand on preconception counseling, the fourth trimester, which is again very important. And end of everything, I think it comes to the optimal management, be it at the stage of preconception when the lady is planning pregnancy, be it during the pregnancy throughout the antenatal period, 9 months, and then lactation and postpartum, and again between two pregnancies. So you can't really let the guard down at any time if we really have to talk about the battle of NCDs that all of us want to fight, win, and even prevent, if that we can achieve. So one important question that always is asked is oral versus metformin. I think you spoke very beautifully that as and when required, metformin has been found to be safe, but then yes, there are indications for insulin where insulin needs to be used. So when it comes to EGDM, which is like early pregnancy, what is your take on what should be the drug treatment at that point, pharmacotherapy?
Again,
Somebody who's
Shalini,
about 6 weeks, 8 weeks, 10 weeks, where we've just picked up GDM.
Yeah, it depends on the blood sugar level. If
Yes.
it is fasting 126 or postprandial reaching 200, straight away we'll start insulin along with medical nutrition therapy. Whereas if the values are just beyond that is just crossing 120, we'll try with meal plan. Then if the patient is accepting, yes, you can go for a very low dose of mixtures. Or if it is not available, the patient is also not accepting, you can very well try with metformin.
Yes. Some contraindications where metformin should not be used. That is again very important because, obviously nobody wants to take injections. If it is a milder degree of dysglycemia, yes, we can definitely offer them metformin. We have some off-label data on Voglibose studies that have also come in. You yourself have published.
I have done only on acarbose, Shalini.
Acarbose,
I
okay.
have been using since 98 when it is introduced because we usually have postprandial hyperglycemia in most of the patients where the insulin actrapid when it is used, it was not coinciding with the food that is rise in blood sugar. It had a peak beyond. So we had hyperglycemia as well as unwanted hypo beyond. So we added acarbose along with insulin. We have never used alone. We have added acarbose to insulin. It delayed the peak. It coincided with the actrapid, that is regular insulin, and we had a very good control.
I think very rightly said, Avthani, because
in National RSSDA Cochin and also at ADA as an abstract.
Acarbose will not replace insulin therapy, but in addition to short-acting or analogs,
yes,
if acarbose is added, that will blunt the postprandial peak, and it is very likely that most of your patient will be able to be in a target range of 120 or less than 120 milligrams.
And we do have some reduction in the dose of insulin also.
Of course.
Yes. A lot of
And
our
we have never
gynecologists
used Voglibose. We have never used because Voglibose is systemically absorbed.
systemically
Whereas
absorbed. Yes,
acarbose just
acarbose.
2% and it acts locally.
Right. A lot of our obstetrician colleagues, right from the stage of preconception, will write a metformin to these ladies, and we continue metformin all through pregnancy unless until it is contraindicated. So few factors where I feel metformin should not be continued, of course, when there's a risk for prematurity or a small for gestational age baby. We talk about GI intolerance, lady cannot tolerate, she's having a lot of gastritis, that's a different issue. But certain situations where you have, intrauterine growth retardation or you have a placental insufficiency, I think those are the indications where metformin should be stopped. If you
Yes,
see,
I have mentioned all the contraindications
yes.
also. Those
So those
places
are
we
very
cannot
important
use. Yeah.
contraindications. Otherwise, I think it is a safe drug to use. Lactation, ma'am. Your comments on again.
Again, again, as far as I was, because of short of time, I cannot show the evidences. It has been again found to be safe in lactation also. They have found that after some hours, it is very minimal in the milk. And 4 hours later, they have found nil in the baby milk also, milk secretion after the conception of metformin in the mother. So it is found to be very safe in breastfeeding also.
Right. Another small comment on the newer drugs. We are using a lot of GLP-1 receptor agonists,
Yeah, I told all
SGLT2
that, no?
inhibitors.
Yeah.
So
It has to be
just a
stopped. If
revision.
at all she is planning for pregnancy, it
Yes.
has to be stopped 8 weeks
2
prior.
months. Yes, 2 months
2
prior.
months.
So all these newer drugs should be ideally stopped 2 months prior. So I think preconception is a very low hanging fruit. This is the time when, somebody is planning pregnancy. So I think all the factors that you stressed become very important if we want to avoid complications and have a smooth pregnancy. So any more questions do we have from the audience? Else we can wind up. I think we're already way over time.
Yeah.
So I think we've had a great symposium today, a great start to the CMRE International Symposium in Diabetes, the 12th one in a row. And like always, we always start the first day as a virtual DIPSI CMRE Symposium, where we've had stalwarts right from Dr. Seshia sir, our patron, our godfather, the father of GDM in India. We heard from Dr. Hema Divakar, again, a very accomplished obstetrician who's taken GDM to the global scene. And of course, we've had stalwarts like Dr. Sujata Mishra ma'am, Bhavtarini ma'am, Samar Banerjee sir, who've shared their knowledge. I'm sure our delegates go home wiser today when it comes to diabetes and pregnancy and GDM. With that, I would like to thank all my faculties for sparing time and joining us today virtually. And of course, the delegates who are the backbone of any meeting. Thank you for joining in.
Thank you.
And I hope it's been a great session. And tomorrow we'll be back again on a virtual platform with the AASD CMRE Joint
At 3
Symposium,
p.m.
which is with the Arabic Association for Study of Diabetes. And we'll have our speakers from Cairo and the Arab world who will be sharing their knowledge on different topics related to diabetes. So I'll request everyone to log in again tomorrow at 3 p.m. for this very important CMRE AASD virtual symposium. After which Sunday, we have the physical symposium at Lee Meridian, New Delhi. So thank you so much, everyone. Thank you, RX Events, for facilitating this virtual meeting. Thank you. Have a good day.
Thank you
Good
all.
evening. Namaskar.
Thank you.
Thank you so much.
Thank you.
Thank you.
Thank you.
everyone.
Thank you.
Yeah. Thank you.
Thank you, ma'am.
Thank you, both of you. Very